I'm Susan Solomon. I'm the CEO and founder of the NYSCF Research Institute. And thank you so much for joining us this evening for a deep dive into the great promise that artificial intelligence holds for diagnosing, researching, and treating mental illness. I am really delighted to have Dr. Chris Gregg with us for this conversation. Chris is one of our esteemed NYSCF Robertson Neuroscience Investigator alums, and currently he runs a lab at the University of Utah and is an entrepreneur. I will let him tell his own story, but in summary, he has a unique perspective as both a top research scientist, a patient, and an entrepreneur, which led him to combine his insights and talents into a new artificial intelligence-focused initiative called Storyline, and he will tell us more about it this evening. After over a year in this global pandemic, I think we can all agree that a huge section of the book that is written on this is going to be devoted to the mental health crisis with the anxiety, depression, and other mental illnesses that really have been skyrocketing in their prevalence. The enormous toll that this pandemic has taken and continues to take on our collective mental health, the isolation, remote work, and the thousands and thousands of people who lost loved ones without being able to see them in their last days or properly mourn their passing. May is Mental Health Awareness Month, and so it's really critical, I think, to bring attention to that because we as a society have to acknowledge how harmful mental illness can be and that we really, it's just way past time to dismiss the stigma that surrounds these conditions. We are all struggling to maintain our mental health, our equilibrium these days, including as we, set our masks aside for portions of the day and begin to come back into contact with other people and so forth. And it's really important, more important than ever, that we are able to talk about these issues and get the help we need. We're talking about the entire world. And so now more than ever, we have to have better tools and scalable tools that allow us to understand, diagnose, treat, and ultimately prevent mental illness. With the pervasiveness of smartphones and the really significant advances in artificial intelligence, we have an extraordinary opportunity to leverage these technologies to take on mental health in entirely new ways. So before we dive in, I want to acknowledge the support and really transformative partnership of Andreas Dracopoulos and the Stavros Niarchos Foundation, which has made today's talk possible and other events like it. Currently, we're a nonprofit, so I have to always be on the lookout for whatever we can do to be able to meet our mission. And we currently have a matching grant challenge if you're interested in supporting the educational content like today's event. We encourage you to submit your questions via the chat function, but please note we are not able to answer any personal medical questions. We're going to be focusing today on the latest research, current treatments, and the road to better treatments and cures for mental illness, and the promising new approach that you'll hear about today. So, Chris, welcome. Thank you so much for being with us today. Please, in your own words, what is Storyline and what inspired you to start it?
Susan, I just want to say thank you so much for the opportunity to speak with you today. I mean, it is such an incredible period in history. And so we're getting an opportunity to reflect on a lot of problems. We're going to talk about a lot of solutions today, which is pretty exciting. Storyline is a new technology platform that has a lot of different applications in the world. It aims to discover and deliver new models of health and disease to improve drug development, care, and medical access for patients at massive scale, so globally. And there's a component to it that is delivered through the smartphone or through a tablet or through a computer. And then there are other components that are involve software and different platforms. And I think we'll get into some of that as we move through the discussion today, and I'll unpack some details and show some information. Maybe it's useful to start just with a little story about storyline and how it came to be. My background is in genomics initially, and when I was
just explain what that is.
Sure. So my day job involves sequencing the genome, the DNA sequence in our cells, and then trying to understand what different parts of the genome, different pieces of DNA do, and how they affect our behavior and health. And that has been my day job for over 10 years. And when I became a New York Stem Cell Foundation investigator, I had the opportunity to use the resources that I got to explore some totally new ideas. And one of the ideas that we got interested in was whether we could apply some of the big data approaches that had been used to make sense of the genome to make sense of behavior. And at the time, behavior just seemed this infinitely complicated, dynamic, and nonsensical thing to really study objectively at scale. But over the next several years, we made some major inroads into how to understand naturalistic patterns of behavior using machine learning and artificial intelligence. And that was very exciting for me. I studied mice at the time. And yes, mice are cute and fuzzy, and we can sure learn a lot from them, but they're not the solution to everything. And then in 2018, I went from being a biomedical researcher trying to solve people's problems to suddenly having a big problem of my own. I was diagnosed with stage 4 cancer in late 2018. And I went from being somebody who imagined what it was like to be a patient to suddenly being a patient and seeing the realities of the problems that clinicians face, the problems with the research and biomedical research enterprise and how it interfaces with clinical care. And, to kind of, I'll maybe insult some people or put them off, but I know that, these discussions can be quite, it can be provocative and beneficial to have some radical candor as we discuss some of these things. As I made my way through to the road of a cancer diagnosis, there were many opportunities when my disease could have been caught earlier, but it was misdiagnosed. And over time, the disease progressed and it spread and it moved through, my hip and back and spine and ribs and all these different places. There were even situations where I'd had medical tests and the report had come back saying that I had cancer, but the doctor was busy and accidentally missed the information. And as I kind of got through that process, you just kind of I started to realize more and more how difficult it is for doctors to manage patient needs at massive scale. And part of the problem is that knowledge is so siloed. Some people are extraordinary experts in a small area, but if a patient walks through the door that doesn't fit in that round hole, then they're not well prepared to deal with that situation, and they are vulnerable to making a mistake. So,
for me, put the patient in that round hole.
Yes, exactly. They have to kind of fit you into what they understand and know, and that's human nature in a sense. You kind of get categorized that way, and they only have a limited number of tools to deal with you. And so one of the big challenges that many patients know is that you have to kind of run around and beat the bushes to try to find someone in the world that has a solution to your health problem. And if you're lucky, you can find that person or those people. And if you're not, you may never come across them. So that's a knowledge distribution problem. Mm-hmm. When I was diagnosed, the treatment plan for me was palliative. And so that means that there was going to be no attempt to cure the disease. It was just a kind of quality of life maintenance. But because I've been so lucky in my career, I had an opportunity to reach out through a network of scientists and doctors and cobble together a plan. And what came out of that process was the recognition that a solution to a complex disease like cancer is not one drug. It's a combination of many things. It's a combination of drugs. It's how you deliver those drugs, the timing of those drugs, the sequence of those drugs, how you interface the treatment with using the drugs with different dietary interventions. And so the solution ultimately turned out to be a very complex program that had to be kind of architected for me. And, you know, if care is not just one drug, then we kind of need to integrate that into how we make decisions and design care pathways for patients. So that was a big realization for me as well, all of those components. And I had the opportunity to kind of stand back and look at my profession. And I realized a number of things that I thought had to be fixed urgently. And there were lots of people sounding the alarm bells, but it's not until you're actually in the chair that you urgently need these solutions. And one was, you know, we publish 2.5 million academic research papers every year. Who reads that stuff? Certainly not my doctor. They don't have time to read all of that and integrate it and use it in the best way they can for their patients. Much of that knowledge is just being lost. Wouldn't it be better if there was a system that was architected so that the research and discovery was directly connected to the clinical care? So when I made a new discovery in the basic research setting, that information was immediately piped out to a rural doctor in South Dakota or a leading expert at Johns Hopkins, and they both had access to the leading information, and that was integrated into their clinical decision-making model so that everybody was getting access to the leading care. That would be amazing. That would definitely be the right solution if it could be done. You know, and that also addresses the problem of siloed knowledge. The other thing that I kind of came to appreciate more and more, I think we've all realized, is that genomics isn't going to be the solution for everything. So analyzing our DNA sequence, we hoped that there would be a small number of genes that would match to a mental health disorder, for example, like depression. And then those genes would be the targets for the drugs that we would make. And then we have new medicines that would effectively address these disorders. And unfortunately, what's emerged is a much more complex picture where thousands of genes contribute small effects all across the genome, and that influences the risk for a complex disorder. And that's true for most forms of mental illness, and it's true for a lot of the other complex diseases that we worry about, Alzheimer's disease and all.
Yeah, so, part of the redundancy of human beings is our complexity, but it also means that I liken it to kind of Russian nesting dolls, the Matryoshka dolls, that, you know, you think you've discovered something and then inside it is something else and inside is something else. And that's why when you get to artificial intelligence, which I'm going to ask you to talk about a little bit, becomes really, really important because of the sheer volume of what we're dealing with.
That's right. That's right. It's just, it's too much for a single person to possibly make sense of. And the other barrier that we ran into, which also broke my heart because I spent a lot of time, and I continue to use mouse and animal models in my lab, but the drug development industry and the research enterprise in general has started to appreciate more and more that those models really don't capture human disease.
No.
And I know the New York Stem Cell Foundation has been ahead on this for a long time, and the importance of human cellular models, in part because these animal models, you know, they're really not predicting outcomes in human trials very effectively.
No.
So
yeah.
this
we're not mice. We're just not mice.
We're just not mice, and so those big things, the genomes not answering everything, the animal models aren't answering everything, and then there are real problems with how basic research is coupled to clinical care, are huge problems to solve. And the NIH is deeply invested. They have hundreds of thousands of people working in those fields. They cannot just turn off funding to those fields. It's a titanic ship that really cannot be easily moved. And so to come up with a solution that's scalable and would work for everybody, you know, I felt like we needed to essentially step out of the whole system and look at what opportunities, what problems need to be solved, what opportunities there were technologically to solve those problems. And ultimately, the solution, I think, has to kind of come outside of the NIH initially. And that led to Storyline. And so Storyline has identified a solution to these different components. And that's basically my passion in life now, is bringing that to the world.
So I think I certainly can relate. You know, when you become a patient, the urgency becomes personal. I think for many people who are with us today, whether it's themselves or people they love, you know, the problems, whether it's cancer or mental illness, are personal because they're so widespread. And I think you know, the story of misdiagnosis, late diagnosis, you know, speaking with a clinician who is overwhelmed, and despite, you know, all of their best intent, just doesn't really see what's in front of them, doesn't hear the patient, because it's kind of cognitive dissonance, right? It's just not, it isn't what they were taught, you know, they should be seeing, and so they're kind of not looking at it. What led you to apply Storyline to take on mental health? And if I wanted to use Storyline, can you walk me through the process of how I would do that, and what would I have to do?
Yeah, so the reason we started to focus on mental health is because we spent about a year or so trying to identify 3 areas that we could focus on that would have the biggest impact, areas that seemed completely blocked in the current system, but were some of the biggest health problems in the world and social problems in the world. And there's no bigger problem than mental health. There isn't. Before the COVID epidemic, 1 in 5 people were affected by mental illnesses, and 1 in 20 were affected by serious mental illnesses, you know, psychoses and these types of things. The impact of that, even before COVID, was profound. The only real way we've been able to manage mental illness so far, it's horrible to say, is by warehousing people. And that's what's happened. In the past, we warehoused people in institutions, psychiatric institutions, and in the present, we warehouse those people in jails and prisons. There are 10 times more mentally ill people in jails and prisons than there are in hospitals. And so, you know, the reasons they're in prison is for very complex reasons. They are often self-medicating, and they end up getting arrested for something small. And because of a number of rules that we put in place around the war on drugs, and some of the other decisions that influence high incarceration rates, mentally ill people are very, very vulnerable. 40% of mentally ill people have been put in jail or in a prison at some stage. That's incredible to think about for me.
Yeah.
And 40% of people in the jails have some form of mental illness, many of them quite serious, many of them undiagnosed, and many of them untreated. And they often can't get out. And the jail is so sort of stressful that it precipitates and progresses the disease more and more and more. So it gets worse and harder for them to ever get free and become functional in society again. And so it was clear that this was one of the biggest, if not the biggest problem to solve. We got 2.5 million people in prison in the United States. And it was also clear that the current thinking in the field was kind of stuck, I think, in terms of how to develop new medicines and how to even understand the diseases, to be honest. Very famous paper from the leader of the NIH, Tom Insel at the time, and Bruce Cupford, and declaring that the way we diagnose mental illness is not biologically valid. These broad categories that psychiatrists have kind of voted on over the years have turned out to not be biologically valid, and that's been a real barrier for developing improved therapies. So we kind of need a do-over. We need a new data-driven and more objective approach to understand mental illness, define mental illness, and make predictions about who's at risk, and try to intervene early before it progresses or they end up on the street or in prison. And then we need new ways to predict which medicines will work most effectively for a given person. The kind of way we do it right now is through a bit of trial and error. You try this drug and you try that. You tweak the dosage over long periods of time. And often the side effects are intolerable. And so people abandon the medicines and this type of thing.
So I think we can all agree that it is it's horrendous to have 2.5 million people who are mentally ill, in prisons. Many of them, if not most of them, of color, people of color, and I think the question is how do we crack this code?
Yeah.
So in a very simple way, what does storyline look like? I have my cell phone. Is it an app that I look at? Do I talk to it? How does it work, and who interprets it? And
yeah, so it might help if I show some slides, Susan. I'm just going to share my screen for a minute. And can you see that? Can you see that screen? Okay, great. So this is there's 3 entry points into the storyline system because we have 3 people we need to help. We've got 3 types of people. We've got the patient, and then we've got the researcher, and then we've got the clinician. In this smartphone side, that's where the patient it comes into storyline. And the patient can use the storyline app, and they're provided with questions that a researcher or clinician has designed. And they answer those questions, and their response is captured by video. And so they can do that safely in the privacy of their own home or wherever they would like to do that. And they have access to the system and through their phone. Now, on the storyline side, we've put together an artificial intelligence pipeline that analyzes those videos and makes hundreds of thousands of measurements of facial, speech, and vocal patterns.
So that's why you have them talk about their experience and answer questions rather than type them.
Exactly. Typing is kind of a flat data. where you're just capturing a little bit of information from the words that they type. But of course, it's not just what you say, it's how you say it. It's the postures, it's the dynamics of the facial expressions, it's the movement of the eye, the pupil dilation that reflects tone of the sympathetic nervous system, and tremors in the voice, the harmonics of the voice and changes, and the word choice, honestly, how you select different words, how you describe your situation, and how you express yourself and about your illness and where you think you're going. This is incredibly rich information. The nervous system is integrating massive amounts of information from throughout the body, metabolic, inflammatory, endocrine, and pain and physical information, and all of that's flowing up into the central nervous system, the major hub, and that information is being integrated, and it influences our behavior and our decisions. And much of this is subtle, and it hasn't been able, we haven't had the ability to analyze it objectively and make it useful for medicine. So that's the problem Storyline has aimed to solve.
And how does artificial intelligence analyze all this information that people put into the app? What can AI tell us about mental health that otherwise would be imperceptible?
Yeah, that's a really good question. Initially, we use it as a research tool, where the first objective is to go out there, because the way we categorize mental health right now is so imprecise. Our first mission is to get out there in the world and really figure out what is the architecture of mental health? What are the phenotypes that delineate different subtypes of mental health? Because when a psychiatrist tries to apply what we call the DSM-5 diagnostic criteria, it's very hard to fit people into particular boxes. But with an objective kind of scan, like other fields of medicine have scans and lab tests, and psychiatry doesn't have that. They've got sort of long extended interviews where they try to figure out what's going on. So the first thing that we're trying to do is to kind of recategorize and define the diagnoses. And one of the ways we're doing that is by deploying Storyline through the United States jail and prison system to analyze mental health within these populations and build diagnostic models.
Now, how do you actually build in the kind of checks and balances, in the artificial intelligence? I mean, not everybody presents with the same systems, and how do you distinguish between a personality trait which you would attribute to mental illness as opposed to someone who is, I don't know, I'll just, somebody who is just eccentric, or someone who is, just completely focused on a particular creative endeavor or something?
Yeah, that's a really good question. When do we actually need to intervene into mental illness? Into mental illness, yes. So what we're trying to do is move from the current system of reactive medicine, where someone becomes very sick and then we try to fix the problem, to a new type of medicine that we call predictive medicine. And that's the situation where we're able to make very accurate predictions about the risks that this person will progress towards a kind of more clinically relevant pathology, frankly. And we have an opportunity to intervene and save them, essentially, with the right medicine or the right social support. And to do that, what we need to do is analyze what we call behavioral fingerprints of health and disease and mental illness across hundreds of thousands of people. And then what we can do is we can build a map of the trajectories of health and disease over time. And as you go from health and you break out into an arm of depressive illness or an anxiety disorder and all of the different subtypes. So there may be an arm that shows the trajectory out into mild cognitive impairment and then subtypes of dementia, for example. And once you can kind of see that map of how the trajectory of mental health, what does it actually look like from the data, not from subjective diagnostics, but what does the data actually show in terms of the trajectory? Then you can identify the critical branch points and biomarkers from these AI detected phenotypes that say, you're right on the edge of moving into severe clinical depression. And
so in other words, you might be able to actually catch somebody before they've just crashed.
Yes, that's exactly what we're aiming to do, because it's so much easier to prevent a problem if you can see it coming than it is to fix a catastrophic problem that's progressed. Yeah. And sometimes.
So, no, go ahead.
Oh, well, I was just going to say that for mental illness in particular, as it progresses, it's so damaging, not just because of the physical effects on the patient, but their lives really fall apart. If they're married, they lead to divorce, and it can lead to addiction, and then lead to imprisonment. And it's very hard to fix all of that stuff. Yeah. So trying to catch it early is really one of the most important things.
Is there a particular kind of mental illness that Storyline with its AI power is especially good at recognizing?
We think it's going to have pretty broad utility. The one area that I worry about, but I think that we're going to be able to deal with, are individuals who are, what's the word I'm trying to grab? People who are concerned that we're spying on them, or that we are conspiracy, sort of the government. And that is a significant component of some subsets of mental illness, where people become a bit delusional and very concerned that the CIA is watching them and that kind of stuff. And so
we should be looking at that on a very mass level these days.
That's right. That's right. So there will be some cases where I think we're going to have to think very carefully about how to help people the most with this platform. But for the vast majority of the most common forms of mental illness, for sure, depression and anxiety disorders that during COVID are affecting over 40% of people, yeah. Those are going to be very effectively managed and detected and subtyped and ultimately matched to medicines through the Storyline system.
You know, one of the many tragedies about the pandemic, I think, is the children, and in particular the teenagers, who yes. I think, as we always knew, they always were, you know, teens are always just kind of either social, or if they're not social, you have some concern, but they have a great need to be with their peers, and it's having a tremendous psychological effect that really seems almost to have like a biological underpinning. That it's and I felt something, I will say, going into my office for the first time in a long time, having been remote recently. But we now at NYSCF, we have achieved, I think we're over 94% vaccination, which is great. We're going to get to 100% by the end of June. And so when I went in, there was literally an electricity. I don't know how else to describe it. When I saw my colleagues, who of course I had been seeing, you know, day in, day out, multiple times a day, many of them, but just being together, even though, you know, we weren't, you know, giving big hugs, but still just physically being in presence. And I think that, I wonder if there is something, if there's something to that at a biological level that is underlying the tremendous depression that kids, I mean, maybe they would have headed there anyway, but I don't think so. It's just terrible.
I worry about it enormously. Their brains are developing. You know, at the later teenage years, the myelination of all these pathways is critically happening. And obviously there's social interactions. We all remember being a teenager, and it's all about social interactions. And that's where you really learn how to interact and make mistakes and all that sort of thing. I worry about it a lot. And we also know that it's during those late teenage years that a lot of psychopathology gradually emerges. These are the vulnerable, critical stages. So I think, unfortunately, as we get the actual infection cleared up with the vaccines, we're facing a wave of fallout problems around mental illness, and I'm deeply concerned about it, because I know, as we've talked about, where that goes. It goes into the prison systems, it goes into addiction, and it destroys families. So
well, we've been seeing it. And if in so many of the mass shooters, if you look at them, they're either very young adults or older teens. Not all, but it's just that moment where a psychosis develops. And I see it now in my own city, in New York City, where we just, the city is not, it's getting back, but it's not quite as densely populated on the streets and on the trains. So the density is safe, actually makes a city safer. But the kind of acting out we've seen, the horrible, hate crimes against people of Asian descent, the whole range of just kind of awfulness. But in the end, often it's somebody who is kind of muttering to themselves, somebody who's just, clearly ill, and not always, but a lot. You've mentioned before that certain mental health patterns can be indicative of something actually going physically wrong.
Yes.
Can you explain how assessing these trends could have broader implications for illness outside of mental health?
Yeah, so we think, well, I'll just give a little perspective here that, for much of my career, I wanted the genome to be the ultimate solution. And then I studied what's called the epigenome for a very long time. And the epigenome, so the genome that you're born with is the same one you die with. It doesn't change. You lose your job, you get COVID, you become depressed, or whatever challenges you face in your life, same genome. Doesn't diagnose anything, doesn't predict very much. The epigenome seemed like a great idea, because then it's changing the expression of your genes and the activity of your genes. And if you could measure that, well, maybe that would be predictive of some illness to come in the future. But the problem is you can never reach into someone's brain and measure this sort of epigenome of what's going on in there. And so the epigenome was great potential, but in the real world of care, it's not that useful. The excitement for me about Storyline is that, evolution really faced this problem of having to build a system that continually monitors an organism's health, all of its organ functions, all its endocrine systems, all its metabolic needs. And that's the nervous system. It's doing all of that. It's the super precision medicine system that we have. And it tells us to take the right actions when we're hungry, when we're thirsty, and all of these inflammatory things are happening, to rest, to sleep. That's what it's doing. We've just never really had a system to measure it precisely, accurately, and at scale, and make use of it. And so I think Storyline is the opportunity to really break this new field open.
We've seen an explosion in virtual platforms and apps. I think I must have loaded on my phone and probably not looked at, 4 or 5 meditation apps. Somehow it's calming just to put them on my phone. But the advantages of an app for tracking mental health certainly seem enormous now when you're looking at a huge population. How would it complement conventional approaches like psychotherapy, which obviously are not available. There aren't enough, psychotherapists to deal with the number of people that we have in a conventional way by a long shot.
It's a super important question. And I think that the first application, or one of the first applications, is triaging. So who needs mental health, who needs psychotherapy, one-to-one, face-to-face care right now, and who can wait a week or a month? And that's kind of the initial system that we need. We need a better decision-making tool to identify people who are right now approaching a strong risk of suicidality, abuse, or a high risk of moving to addiction. And they need face-to-face care, perhaps earlier than someone else. And then we need to make accurate decisions about how much face-to-face care does a given person need. Some people may need weekly 30-minute or 1-hour sessions, and other people may be able to manage their health with monthly sessions, for example. So making the strain on that face-to-face care managed a little more effectively is one application.
So how do you manage both data security and also what many people feel, just because of the way the field developed, of kind of a white bias? How do you factor in cultural differences?
Those are really important questions. So even before we really started working on the technology of Storyline, it was clear that the first major problem to solve was to make sure that we were the most secure platform that we could be. And so that didn't mean, that meant exceeding HIPAA and GDPR and high tech by far, and using really military grade security solutions. And so that was kind of how we approached that. The field in and of itself, just like, when I was a kid, people didn't wear seatbelts in their cars and there were no airbags. But now we know, that if you have crumple zones and all this kind of stuff, cars can be much, much safer. The same is true for AI and data security. We made a lot of, the field has made many mistakes and learned about better and better practices to protect people's data. And it's much better than it has ever been in the past. And so that's going to keep going forward. One of the things that we think is very, very important for data and patient data is that patients themselves always maintain control over their data. So if you donate data or participate in a Storyline study, you're in control of that forever. This is not like Facebook, where Facebook owns your data.
Right.
You can go in, you can delete it. It's your data. And I think that kind of democracy, even though it gives entrepreneurs, I guess, and investors and things like that, it makes them anxious. It's frankly the right way to do this. So that's how we approach it.
Especially with mental health in kids. I know as a patient myself, I had two experiences this past week. One where I was asked to fill out a form and check medications. And I'm like, I don't take any of these drugs. So I went to get all of scrub the list, and it said, none of these will be removed until the removal has been approved by your physician. And this was, I was just going to get my glasses checked, it was completely run amok. And then another thing that I got was a query from my main hospital where I see folks to deal with my own cancer is, would I consent to linking all of my, doctors I might have seen or see at different places together in this app? And I kind of looked and I thought, oh, well, that's a sensible thing to do. And then I thought, I'm not going to even touch this because I have no idea who owns this app. Is this some kid bright idea trying to make a buck? What's the security here? And I think so I didn't do that. But when you think about your children and, dealing with mental illness and children, it's a much higher bar. But to go back to the cultural bias question,
very important.
Addressing that, because I know that was front and center for you.
Yes, I think a lot about that. I'm very concerned about it. There's a couple of major points to make. One is the way AI works. AI, by the way, artificial intelligence is kind of a subfield of machine learning, and in particular, the technology that underlies it is sort of loosely modeled on how the brain works, where you've got these nodes that are like neurons, and those nodes connect to each other, and there's different layers. And when we talk about deep learning, what we're talking about is these neural networks, and they have multiple layers. So that's why they're deep, because of the layers. And there's an input side, and the information goes in, and the connections between the nodes and the layers are tuned and changed and what we call trained. And then there's an output, and that makes a decision and classifies the input into a particular bucket. We have some control, and we can tune the network until it makes the right decisions and puts things in the right bucket. So imagine the problem of trying to diagnose depression, and you're training a network to diagnose depression, and you put in a lot of images of people you know that have depression, so you've labeled them, and people that are just random, healthy people, people with all kinds of conditions. You throw that against the network, and it trains and tunes and makes all these decisions for you. And lo and behold, it's perfect. All the depressed people are put in that bucket, and all of the people that are not depressed are put in the other bucket. And you think, wow, I've just built a perfect diagnostic AI algorithm for depression. But the problem is, when you look at the actual images, you discover that just by chance, all of the people with depression have the color yellow somewhere in the background. And the network classified all the images based on the color yellow. And you never knew. And so you go out into the world, and your algorithm doesn't work. And there's a horrible yellow bias that's been built into your algorithm. It's catastrophic. So that is the type of problem that can happen for biases around, just massive errors, frankly. And so one has to be very, very cautious of the data that you feed a neural network to build an algorithm. There has to be a number of sort of steps to test what they call the generalizability of the classifier, and does it work for all kinds of different people, cases, and scenarios.
So you're training it on enough different kinds of people. So people who are of different ethnicities, and so you've got kind of a diverse population, and you're monitoring for that yellow wall in the background, or the green shirt, or whatever it is that is kind of the erroneous commonality. I'm going to take your word on that. I want to move to this question, which is how are clinicians and researchers going to be able to access that? What is your vision? And I should say that right now you're in the process. You've built this, and you're in the process of kind of figuring out the funding strategy and getting ready to be able to roll it out. But how do you really see this optimally working? So I'm taking care of a population. Either I'm a psychiatrist or a psychologist, or I'm a social worker, and I'm in charge of a large population. How do I make a tool like this work? Similarly, if I'm a researcher and I want to be able to use this to advance my research into mental illness, how would I use it? So if you could take those two scenarios.
Thanks, Susan. I'll just sum up on the last point to say that there's
I know you're going to get there, so I want to know the world that we're going to be looking at in not too long.
I hear you. I hear you. The so their storyline serves the clinician, the researcher, and the patient. And on the clinician side, what we've done is to build that pipeline between basic research and clinical care and make it so that they're seamlessly integrated. Clinicians get access to a telehealth solution. So they have kind of a next generation telehealth solution that Storyline has already built and is operational. It enables video chats like we're having now that are live. It enables asynchronous video messaging so that a patient can leave a video message and the clinician can look at it during their downtime or time when somebody canceled a visit, for example, which is not billable time, and they may be looking to potentially use that time more effectively. And that framework enables clinicians to label patients. And that's important for algorithm development, where they can look at a video message that a patient has left and they can make a judgment about how's that person doing. And they can label them as, it looks like Chris, he looks like he's getting depressed, or his eyes are red. Maybe he's not responding to the new medication very effectively. And I need to reach out to him. We need to make a change. And you label that and you type in some notes, and that is stored and saved. And so that whole system is there. And then all the messaging is also built in. Messaging to message Chris, the patient specifically, but also messaging on bulk to message many, many different patients and manage that whole care. And then these AI algorithms that are being trained and built by the researchers and the clinical researchers are being migrated and built into the telehealth front end so that there are decision tools and that can be used by clinicians to make diagnostics, to make diagnoses and to build care pathways and to classify patients. So the whole sort of process comes out on the clinical care front through this telehealth system. The researcher, so somebody like me, logs into the storyline.care platform, sets up an account, and can design programs or assessments, questions, different types of questions, and then those can be deployed at massive scale to thousands, hundreds of thousands of people to their smartphones when they get, and that's just done by either posting a link on a website and they can click on the link and then boom, they're into the program. It can be done by texting it to people. It can be done by emailing it to people. And they click on the link immediately takes them to the Apple or the Google Play Store, download the app, and they're brought right into the program. They answer the questions or do the assessment that the clinician or researcher has put together, and that information is captured by video and it's deleted off the device. So if the device is lost or stolen, personal data is never there, it's in the Storyline vault, stored under super security, and it cannot be connected to that person's personal information. And so all of that can then be processed through the AI pipelines, and the researcher has control just by pushing buttons. It says, select all these people, run them through the AI, and then that generates massive amounts of data that can be used to build models.
So as a patient, your information and the interpretation would not be directly returned to you. It would be returned to the clinician who's caring for you?
Yes, at this stage, that's exactly the goal. We are not at a stage that we want patients to be making any sorts of decisions based on these AI tools. AI is in its infancy. There's no question that it's the future. There's no question that it is the solution for most of these problems, or at least part of the solution. But it is not ready for patients yet. It's ready for research, and it will be ready for clinicians very, very soon. And there'll be experts, and those people will make a judgment call about whether it's working well, and it will get better and better.
Right. So it's very early days, and it's you're not going to just kind of speak into it and then be told you need to take this pill or go walk around the block or something like that. I think it's really important, and I think it is important for everybody to understand that this is truly a new frontier, but it's an essential new frontier. And if we think about the suffering, we look at the suffering in our country that we see, but then if we look at the suffering in other countries where there is very little access to healthcare, people are there's an enormous population, poor countries. We're going to have to use this tool and make it better, because I don't see, we're not going to have one-to-one psychotherapy for millions of kids in third world countries that are just dealing with the kind of traumas that we saw really in much smaller scale in wars.
Yeah.
So well, I think this is really extraordinary. I look forward to to hearing more as things evolve, and talking with you again. I think we should also do a deep dive into some of the other applications in cancer, and kind of look specifically at different populations. But I think it's very, very exciting, and I want to thank you for for joining and having this conversation today. I know that people really are fascinated, and if people would like to learn more about Dr. Gregg's platform, just take a look in the chat, and you can go to there's a link. You can go to NYSCF resources, and you can learn more about it. And if you have questions, you can also reach out to us, and we've given links, and we will be hearing from you again, Chris. This is very, very exciting, and thank you so much for taking this on.
Thank you. It is a life mission now, and I'm so grateful for NYSCF support. Truly,
well, we're so grateful that you've chosen to pursue this work. Stay well, stay safe, and we look forward to continuing the conversation.
Thank you. So nice to see you.
Good night.
Good night.